Hello and welcome to Health Matters on Channels Television. Thank you for staying with us. I am Mary Alale Yusuf. For several hours every night, if you are fortunate, you close your eyes, your muscles relax, and your consciousness of the surroundings is suspended. Everyone deserves several hours of sleep per night, but some are not so lucky. Sleep apnea is a disorder characterized by repeated stopping and starting of breathing during sleep. You can imagine that it would affect sleep quality. One of the symptoms of sleep apnea is feeling tired even after having a full night's sleep. Men are 2 to 3 times more likely to have this disorder than women. To talk about sleep apnea with us is Professor of Otorhinolaryngology at the University of Health Sciences, University of Abuja, at the College of Health Sciences, University of Abuja. Professor Titus Ibekwe is an ear, nose and throat surgeon at the University of Abuja Teaching Hospital, president of the Foundation for the Sick, and a health policy and management specialist. He joins us from our Abuja studio. You're welcome to the show, sir.
Thank you very much, Mary, and Happy New Year to you and our viewers.
Thank you. Let me start by asking you, why does somebody's breathing stop while he's asleep?
Yeah, just as you did in the introduction, it's an abnormality, it's a sleep abnormality, just as we have some other disorders. So it's a disorder that's not supposed to be. The normal situation is that whether you're sleeping or awake, the respiratory drive should still continue. But in this abnormal situation, it's noted that intermittently there is cessation of breathing. And this is usually associated with snoring. But beyond that, for this to qualify as sleep apnea, this cessation of breathing must last at least 10 seconds, so that somebody who is just snoring due to tiredness, but there's no cessation of breathing, doesn't have sleep apnea. So the system has, reverted from its norm here, and usually due to obstruction on the breathing passage. And it could be at different segmental level. Sometimes it's monosegmental, sometimes it's multisegmental, right from the nose down to the nasopharynx, which is the back of the nose, to the oropharynx, which is around where we open our mouth, the opening of the mouth and the nose where they are connected, down to the hypopharynx, which is the level below the mouth that now connects to the larynx that branches into these 2 trees that will link to the lungs. So once you have any significant obstruction at this level, so this is very likely to happen during sleep. So you will realize that the breathing will cease for a while, and that is why it's called apnea, meaning lack of oxygen within that period. Everything is like flat. And usually breathing effort still continues, but there will be no airflow in the process. So you see the person almost flat for a while. And of course, your guess is as good as mine, just as our viewers. Oxygen is very important in nourishing the tissues of the body, especially the brain tissue. So, and also is important for the heart to perform its function. So when this happens, that means that the essential brain tissues, they are deprived of this oxygen which they need for their metabolic processes to be alive, to do all the interconnectivities and helping in coordination of our activities, our meditation, our thinking, and everything that we do. And incidentally, when this happens, a signal is sent to the heart. The heart struggles on its own to start, putting in more effort towards a higher level of pumping of blood into the entire system. So that is why over time you realize that the heart become what we call hypertrophic, which is the muscle becomes so much because it's overworking itself. And there's danger of the heart failing in this process.
Okay,
when
let
you
me
have
just
this chronic
let me just butt
obstructive
in
sleep
there.
apnea.
Let me butt in there, Professor, and ask this question. I understand there's an obstructive sleep apnea, which I suppose is what you have just described. Then there's a central sleep apnea. What's the difference?
Excellent question. Central sleep apnea that means the problem is primarily from an abnormality or a damage in the brain or the cerebral center or the higher center. So when that happens, then you call it central. Then if it is coming from this peripheral area, which is the respiratory tract, which is the commoner one, then it's obstructive sleep apnea. They're almost the same thing, but the only basic difference here is that if it is central, both inspiratory effort is lost. So the person will just be completely quiescent, as if the person has passed out. Unlike if it is the peripheral one, which is the obstructive sleep apnea, you still see effort at breathing. Inspiratory effort will still be there, only that there will be no airflow. All right. The end point is basically the same because there's lack in this oxygen that is needed to circulate.
Are there tendencies or risk factors connected to this disorder?
Yes, there are. You've highlighted the common ones. Incidentally, the males are more predisposed here than the males. Obesity, which is excessive weight gain, is one of those common factors. And this is not far from fetched. There will be a lot of redundant tissues and redundant folds, even within the airway, the respiratory tract, which will be flabby, so that during sleep, these floppy tissues will be obstructing the airway. For such people, they have short neck. So those that have short neck, they're also prone to having this. Then, as we know, there are a lot of comorbidities that are usually associated with obesity, diabetes mellitus, hypertension, and all those. Incidentally, it's like a vicious cycle because the prolonged sleep apnea itself could predispose to hypertension because, the peripheral pressure in this circulation becomes very high. And over time, this person can develop hypertension. A lot of them will develop edema, which is swelling around the feet, and pulling of fluids down there. Suffice to also say that lifestyle has a role to play here. Those who consumes alcohol, cigarettes, and even certain beverages like coffee, and their related substances. They usually take this late in the night. It is known that such people are more prone to having sleep apnea when compared to those who do not. And those who have had head injuries in the past or in the recent time may also be predisposed to having this. It is also known that there's some level of genetic predisposition because, as we know, this tend to be commoner or somebody who is coming from a family or a home where you've had some people who have had history of this will be more prone when you compare to another person who is not from such a lineage, So these are some of the factors that commonly lead to sleep apnea, sleep obstructive apnea.
Okay, so
and, the level of damage.
we'll talk about the damage later, but if a person suspects that he has sleep apnea just because he has daytime sleepiness, it means that it's difficult to detect. Perhaps the person is waking up and sleeping several times a night without really knowing. So is it possible that people with sleep apnea today don't even know they have it?
It is possible, but information is power, and knowledge sharing is helpful. But again, those that have life partners whom they share bed with, it is easy because your life partner will easily notice this when it is happening. You snore a lot, struggle from one side of the bed to the other as if person is being suffocated, and after such rapid activities and action comes a moment where everything just goes flat and quiescent. It could be very scary, as if this person has passed on. Such situations, you realize that your life partner will hardly sleep. The level of snoring will disturb his or her own sleeping. And witnessing this happen, some people will be foaming from the side of the mouth when the apnea is on, but from this respiratory effort that is not yielding. So, and when you wake up in the morning, your system will just tell you that everything is not normal because you'll be extremely tired despite having spent hours, on the bed as if nothing has happened, as if you have not slept, And before the day progresses, the daytime somnolence will set in, which the person will be feeling sleepy when it's not supposed to be. And the level of coordination and mentation will not be as, as sharp as it used to be in the past. Such person easily gets annoyed, and over time they start putting on weight, and so on and so forth. So all these are
really
pointers.
Vicious cycle. Really
there will be a red flag. Yes. Yeah.
Is there a pillow or sleep position that can help the disorder? Like maybe sleeping on the side?
Yeah, your questions are really very preemptive and very important too. Now, lying on the back worsens the situation, and is not far from fetched. The reason is that when you're lying on your back, or you're lying on your back especially, the tongue falls back and completes the process. So whatever slight air space that was left for breathing during sleep will be completely obstructed. So they tend to get better or better relieved if the person is lying on the side. Left lateral tend to be better than lying on the right lateral, but is individualized. Certain people will feel better when they're on their right rather than on the left. And again, certain undulated pillows that will retain the contour of your head and neck when you drop it there, so-called memory pillows, will help because it helps you to maintain your head and neck in fairly straight and elevated position, so that the alignment of the airway, the air tube through which the air flows and passes through, will reasonably be more patent when compared to somebody whose neck is twisted to one side or, who kept rolling from one side to the other. So positioning, yes, could be helpful, but ultimately, all this depends on the severity of the apnea that one is suffering from. Because once is severe apnea, usually moderate to severe, most of the time this positioning will have little or no effect. But when it is mild, the positioning will tend to help. And by mild, moderate, and severe, we are referring to the number of apneic episodes, as this cessation of breath episodes that one develops within an hour of a sleep. If it runs between 5 and 14, per hour of a sleep, then you can say that this is mild. But once it's more than 14, ranging from 15 up to 29, it is moderate. Anything 30 or above is severe.
Okay, Doctor.
And this moderate and severe, they really need an immediate attention.
Prof, we really need to go on a break.
Experts.
When we come back, we'll speak more about that. We're going on a break now. When we come back, what the doctor says about episodes of apnea and how to handle them. Stay with us. Welcome back. This is Health Matters on Channels Television, and we're talking about sleep apnea. So far, the picture has been looking really bad, but the good news is that the doctor can help you. If you want to ask any question on sleep apnea, call 0808-054-2233. You can also send a message on X at CTV_Mary A, or send me email to moalale@channelstv.com. So, doctor, we were talking about episodes, apneic episodes, as you call them. Let's say the person comes to you at the hospital and you find out that he has a condition you have to help him with. What do you do to relieve this problem?
Thank you very much. Each situation is handled according to what you see, or according to the outcome of your interaction with this patient and subsequent investigations. So first is to ensure that we establish that this patient really has sleep apnea. So which through interview of the patient, and indeed the partner, if it's somebody who has a partner, will be the first lead. And subsequently, we have to perform certain physical examination and investigations. So we take a look at the frame of this patient. We also look at the airway. This could be a pointer. We may be able to see certain things that will help us take a decision. Then polysomnography is the standard, to be able to clinch and diagnose the level of sleep apnea that the patient has, whether it's mild, moderate, or severe. So we connect this, not bulky equipment, it's easy to handle, but people will go home with some portable ones and get it connected around them and their body while going to sleep. So it will help us to record the activities during sleep. Usually, sleep has two phases. We have the one we call the REM sleep, rapid eye movement, and the non-rapid eye movement. So all this will be recorded. Both of them are essential, but the rapid eye movement is not as fulfilling and as relaxing as the non-rapid eye movement. The rapid eye movement is the one that will drive you into having some dreams that you'll be able to remember by the time you wake up. While the non-rapid eye movement, is the one that will give you that most fulfilling sleep with little or no dreams. And most of the time, if you dream, you won't be able to remember anything. So a combination of these two is needed, for one to have a fulfilled sleep. So this little equipment that will give the patient, get connected in the system, will take all the essential readings and recordings, including the number of this cessation per hour and the duration of each, and even the level of oxygen circulation within the system, the respiratory rate, the pulse, the blood pressure, and all this. So we'll be able to have all our essential information.
If I can quickly butt in, I know there's loads of information, but not so much time. Can you quickly go to the intervention? What do you do for the person?
Right. Okay. So first, if it is a mild sleep apnea that the patient has. So we'll start with the simple things first, like the position in which we have already discussed. Lifestyle, where the patient, especially the feeding habits, make sure that all your meals, you're through with them early enough, usually before 7 p.m. And you should be able to be awake minimum 2 to 3 hours to ensure there's digestion. And if you can take a walk before going to sleep, that will be helpful. And avoid alcoholic beverages and the other ones we have mentioned, like caffeine and the like, Then deliberate effort to lose weight for those who are on the bulky side, especially when we check their index and find out that they are obese, So that deliberate effort to lose weight will also be very useful here, Then we can move over when we're talking of moderate, and all these things have been done and is not helpful or useful, to CPAP. CPAP is, what people will call the magic wand machine that does a lot of wonders. It helps, continuous supplies a continuous chain of, pressure, respiratory pressure when the patient is sleeping, and it's like a small machine which pumps in air within it. You have a tube connecting it. If there is time, we'll be able to show this later on before we run out of the program. So they fix it. You have the different nose pieces or the facial pieces, depending on the one that best work for you. So you wear it and switch it on. So it's the function is to make sure that the airway is patent. So it keep on giving this positive pressure, continuous positive pressure within the airway while the patient is sleeping, which will keep it patent. It will not allow those redundant folds that is actually obstructing that airway. So it helps you to have a good free flow of sleep all through, and you wake up. It's not known to be, to be dangerous to the user, except that there may be some little side effects, which definitely will be explained to the person using it, such as when the mask is not well fitted, the air is blowing, it will make you very uncomfortable, it will make the eye dried up and all those. But this helps close to 80 to 85% of individuals who use it to achieve a good sleep. Then, if your findings suggest that the patient or the candidate needs surgery, so there are certain levels of surgery that we also perform. The commonest is the one they call the UPPV, uvulopalato-pharyngoplasty. So this means those individuals whose level of obstruction is at the oropharynx, that's around the connection between the lower part of the nose and the mouth, So if the tonsils there are so huge, obstructing the airway, the uvula is very big and long, causing further obstruction, and they have redundant folds, of soft palate. So all we do is to go and reshape these things, do like a plastic surgery around them, remove those redundant tissues, strengthen and tighten those area, so that the flabby tissues while they are sleeping, that will stop. And patients will tend to have a better quality of life. Sometimes the surgeries may fail, so you may still need to carry on with your CPAP, and explore the other options. So a combination may be needed of 1, lifestyle, 2, deliberate efforts to ensure that you lose weight, and then 3, the use of the CPAP, and 4, we may consider the option of using surgery. And recently, there has been an innovation which involves an implant. So you put in an implant, one on the jaw and another one around the chest. You switch it on with a remote control while you're sleeping. They tend to communicate and perform similar activity or function, just like the CPAP machine does, which you fix and you can carry along anywhere you're traveling to and do that.
Prof.
So this is life-saving because, yes.
I really have to cut in. We have to go. But you left the best for last. We're going to have to talk after this program. Thank you so much for the information. It's a wrap on the program. Thank you for coming, Professor.
Thank you very much, Mary. I look forward to the second part.
And thank you so much for hanging in there and listening. If you have sleep apnea, there's hope. Very good hope. Have a lovely day. I am Mary Alale Yusuf.